Welcome to all dear viewers and KSOS members. Tonight, we are here with another edition of our International Master Class series. And tonight, we have selected ocular trauma as our topic for discussion. We try to choose topics relevant to all sections of our members and give them an update on it from international perspective. I believe ocular trauma is of interest to all of us, as this is one field where one single rule or one single strategy may not always work. So we have to take decision on the spot. We have to predict the prognosis, to take the control of the situation, plan things for the present and for the future, either immediate surgery or sequential surgery, repair or destructive surgery or cosmetic surgery, and so on. And nowadays we have newer protocols, AI-based protocols also to help us in decision making. And we are happy that our today's speaker is much reputed in this field, and it's my pleasure to welcome Dr. Rupesh Agarwal, Head of Research and Senior Consultant from NHG Health, Singapore. We welcome you, sir, and it's a privilege for the KSOS to host you tonight. We have two expert panelists. We have Dr. Prashant Bavankule, VR surgeon from Nagpur, who is also a chairman ARC from AIOS, and also Professor Biju John from RIO Trivandrum, who is our past secretary of KSOS. Our special congrats to Dr. Prashant Bavankule on your thumping victory in AIOS election for the second time in a row. And special thanks for suggesting Dr. Rupesh, our today's speaker. Our moderator for today, Dr. Aparna, the young dynamic oculoplastic surgeon and trauma consultant from Chaitanya Eye Hospital, Trivandrum. Our president, Dr. Rajiv Sukumaran sir, was supposed to join us today, and he had an emergency, so he's traveling. I would request Ankit to play his recorded message before we start.
Good evening, everyone. First of all, I would like to thank Dr. Sujit and the KSOS Scientific Committee for the excellent work they're doing in organizing such good academic programs. The masterclass series, the expert talk, and the AI courses conducted as part of Presidential Project are truly benefiting our members. Today's session is particularly special as we have with us Dr. Rupesh Agarwal from Singapore, an internationally respected expert who will be speaking on ophthalmic trauma, past, present, and future. Ocular trauma remains a significant challenge in ophthalmology, and learning from a global expert like him will certainly enhance our understanding and management. I'm also happy that this session is being guided by an excellent academic team. Dr. Aparna as the moderator, Dr. Prashant Bavankule, and Dr. Biju John as the expert panelists. With such distinguished faculty, I'm sure this masterclass will be highly insightful. On behalf of KSOS, I wish the program great success and hope all the participants will be benefit by it. Thank you very much.
Thank you, sir. Now, let me request Dr. Aparna to introduce our speaker and also invite him for the talk. Dr. Rupesh has suggested that we can have discussions in between also. He can pause as and when required. So moderator can take up that also. I'd like to I'll help you by getting the questions from the other forums, like we have also FB Live and YouTube Live going on. And so, Dr. Aparna, please.
Thank you, Sujit sir. Very good evening, respected seniors, colleagues, and my dear friends. I would like to begin by thanking KSOS for giving me this opportunity to moderate this prestigious session. And it's my privilege to welcome you all to this third session of International Masterclass webinar series. This time it is on ophthalmic trauma, past, present, and future. Let me share my screen. Just a minute. Hope it is visible. So, as Sir has already mentioned, ophthalmic trauma remains one of the most challenging areas in ophthalmology where timely intervention and precise decision making decides significantly in visual outcome, and that can be life changing also. And if we look at the time of evolution, yeah, the journey of ocular trauma, we can see that the past has taught us the fundamental assessment, and it was more towards a conventional management, more conservative management. And present is defined by advanced diagnostic tools, imaging tools, and prognosticating tools, and microsurgical techniques. And the future holds immense promise in innovations like artificial intelligence, targeted therapies, and translational research. So today we are fortunate to have with us stalwarts in this field who are not just witnessed this evolution but actively reshaped the evolution of trauma. And it's my privilege to introduce the esteemed speaker of today's discussion, Dr. Rupesh Agarwal. Dr. Rupesh Agrawal is a head of research and senior consultant at Energy Eye Institute, Singapore. He is a globally recognized clinician scientist with significant contributions in different fields of ophthalmology, like ophthalmic inflammation, of the ocular and ophthalmic trauma, artificial intelligence in ophthalmology, like that. He has got an exceptional academic profile with more than 400 publications and an H-index of 63. And his contributions are outstanding, and for which he has received multiple awards and recognitions for his credit. And he is actively involved in multiple international collaborative platforms of research, and he has secured a significant funding that shows the impact and depth of his work. So he is an inspiring mentor, researcher, and actively involved clinician. So we are really fortunate to learn from him today. Welcome, sir. I would like to introduce our esteemed panelists. First, we have Dr. Prashant Honkle, a renowned vitreoretinal surgeon from Sarakshi Nethralaya, Nagpur. He has a vast experience in managing complex retinal cases and ophthalmic trauma cases. And he has received multiple orations and awards at national and international levels. And he is well known for his academic enthusiasm, especially in quiz activities. And he is the founder of Brain Teasers Ophthalmic Quiz Forum that inspired many ophthalmologists, including me. Welcome, sir. We have also with us Dr. Biju Johnson, is Professor, HOD of Department of Ophthalmology, Government Medical College, Kollam, who truly needs no introduction in KSOS family. He brings a vast clinical experience along with a strong background of surgical teaching and PG training also. Welcome, sirs. Thank you for joining with us for today's discussion. So without much delay, I would like to invite Dr. Rupesh Agarwal, sir, to deliver his masterclass. Thank you.
Thank you so much. Am I audible?
Yes, sir.
Yes, Rupesh.
Good,
Yes,
good.
sir. Yes.
Thank you. 1 second. Yeah. Okay, I'll make it full screen. Okay. Thank you so much for the opportunity, and I'm extremely thankful to the organizers for giving me the opportunity, particularly KSOS and Dr. Sujit for reaching out to me. I know Dr. Sujit messaged me a lot of times, but I was just like very poor in responding, and therefore it took us a time. So trust me, this is not going to be April Fool Day. This is real, which happens actually in the real life. So there is no fool kind of thing there on April Fool Day when we are organizing it. Next, thanks to OTSI, AIOS, and Dr. Bhavnakule sir for being here, and he's always an inspiration. As he just before this round he was saying, he is my mentor and inspiration to get into, particularly in the field of ophthalmic trauma. We started with that and ophthalmology in Shankar Nethralaya. I think Nagpur has given me that head start. So being from Nagpur, I've seen. So I'll start with this talk, which I've divided into 3 different sections. And this is a ChatGPT generated kind of a slide, but you imagine how ChatGPT can generate. I don't think ever it will happen in even in future, this kind of theater. I hope one day Dr. Bhavnakule theater will be like this thing, you know, we will be operating and sitting in the center. But we never know. Sarakshi Netralaya will pull up such a thing in Central Nagpur, the way it is expanding. So, but with that hope that we might have that thing. So get into the something which we have learned over past many years about the trauma and where do we want to move forward in the future. So that's one topic, and then I'll speak on the AI in a separate topic. And then I will also try and see whether we need to show certain videos related to some of the surgical skills of the trauma, because I understand there are some general ophthalmologists also on the call. Now, first thing I want to mention to whenever we speak about trauma, so a single man, which we all know is a Ferenc Kun, he has given a lot. I want to dedicate some of this thing which I've done in the field of trauma. He's been my Dronacharya, whether I was Eklavya or not. The reason is that he has done so much of work, and I was trying to do a fellowship with him, but just could not manage. But even though I was not able to do the books he has written, so therefore I put up whether I was Eklavya or not, but he was like a Guru Dronacharya who's been doing quite a lot of work, and he was even able to inspire me. And it took me many, many years before I could actually connect to him. Then over the period of time, I met Dr. Ganga, who was the first person to give me corneal trauma repair, and Caroline Chi also allowed me to do some of the stuff related to trauma here in Singapore. And Dr. Natarajan, of course, everyone knows him, and he's been the giants in the trauma. Then through them, I got into contact with Fasika Voreta, who was the president of the American Society of Ophthalmic Trauma. Again, amazing leader, and she has done wonderful work. And these two young folks, Andres Roosevelt and Annette Hoskin, they are again amazing people, one in Australia and one in Argentina. And if you meet them, then you feel like. So the reason I'm showing that because there are only limited number of people you want to show in the field of trauma. There are not that many people who are passionate about it, but these are some of the key people who have been doing, and there are more as we kind of move forward, but these are things that. So sometimes you want to dedicate some of the things, learnings from these people. So I thought better to show and recognize these people. Then, of course, there are different trauma societies, including Ocular Trauma Society of India, and then Asia Pacific Ophthalmic Trauma Society, which are the two very local Asian one, and we really are proud and honored to be part of it. Some of you are member of APOTS, and most of you are member of OTSI. So these two societies have been doing fantastic work in the field of ophthalmic trauma, which is great. And there is a deliberate reason why I brought up, because there are very limited number of efforts which have gone into the field of ocular trauma. And to start with, what has happened is we start by the naming. So you introduced myself as a Rupesh Agrawal and everything. So it is very, very important that we get the names correct. And here, if you see this slide, I'm excited, I'm also worried. So all this classification were done in 1992 and 1996. So this classification terminology has come up in ocular trauma in 1992, 1996, though we have very recently refined this terminology, and which I'll try and show it to you. What is the current terminology? So first and foremost is that we need to get the names right when we speak to each one across the field, because otherwise you're talking something else and someone else is talking about something. So therefore, it is imperative that to all the practicing ophthalmologists that we need to get our names right. Second thing, we need to continue to talk about trauma. Therefore I call it as an educator. So Ferenc Kun has given lots of talks. He goes different places to talk about it. So I'm glad that AIS has taken up the initiative, and wherever Dr. Bhavan goes and other people from the AIS, they go, they try and keep one session of trauma, which is the way it should be. And this is where which can be helped is by advocating and by probably talking about the trauma. And this is how I probably learn is some of the basics of trauma. So this is all written in the books. But now I'll switch gear to show the videos which get translated from this Ferenc Kun book into in the real life. So just to kind of put into context this learning from the book, there is no point me digging up this skills by taking the picture, but better to show these videos. So let me show another slide deck which present the videos of the different thing. And what I've given there is a do's and don'ts in the field of trauma, so that it put up into proper context. So what we are going to tell here is to see some of the videos. And unfortunately, in the field of trauma, when it comes, you don't require any kind of specialization or a course to be certified as a trauma surgeon. come residency, you become certified to manage open globe injuries. But wherein, if you have to do cataract, you have to do certain 50 surgeries under supervision. Femtosecond, you have to do certain number of surgeries. Cornea, glaucoma, retina, everything has fellowship and all. But unfortunately, the earliest day of the residency, everywhere in India, across the world, the people are certified to do trauma surgery, which I think is something not good. And what can happen because of that, you will get repair like this thing. So do you want the eyes to be repaired like that? I'm sure none of us want. So those people have not read the Farrington book or any of those basic principles. Probably you can go. And therefore, I say that it is important that we continue to advocate about trauma, because you really do not want to do repair like that. And when you actually repair, you need to follow certain principle. This is one of the simple principle which I always say: removing the vitreous. And this is again taken from one of the books, ebook of trauma, written by Paul Sullivan. You can look into the Apple Store and you can download that book. Beautiful videos he has given. So one of the videos where how you to remove the vitreous coming in this thing in the wound edge. And then again, how do you clean up the wound edge? Again, there are certain videos which will tell you what to do, and certain videos which will tell you what not to do. So here again, you are seeing very careful dissection, just to make sure that you are not cutting the actual sclera, because in my early days, when there is so much of blood and all, you might end up causing more trauma to the tissue by cutting the actual thing. Therefore, you have to go very slow, make sure you're in the right plane, and then slowly cut this thing. And again, very carefully making sure that you are actually removing. So this was just about the initial steps of the surgery. Now going into the next steps of the surgery. Once again, we put all this corneal suture, and this corneal suture, when the wound edges are edematous, can become loose. So you need to take into consideration those kind of factor there, that if you're going to put stitches, that does not get loose and they are wouldn't enough tight. Again, very basic principles for most of the general ophthalmologists to remember, that we take care of this particular factor which will come in. Now, wound tightening is another thing. So if a retina surgeon like Dr. Bonpule, I don't think he will like it if you've done a trauma repair and then it's going to leak like this thing. So you have to make sure that they are enough watertight. Again, here it's a very bad wound and should not be very leaky or tight wound. So the first one was a leaky, but here you will see it has put up very tight. So you just need to balance and make sure that your wound tightening and all those things are properly taken care. When we move to the next step, again, this is about the locking the knot, not so important. I'm sure all of you do that very well. This is something which I wanted to show, and I'm sure all of you know that, but just again, in different cases, how do you pick it up? You go there. So some people do this thing, but I think if I was there, I would have taken at the limbus and then taken at the apex here. But the idea is that to divide the wound into 3 segments. So one is this apex, one is this limbus, and one will be the another limbus, so that you divide it into 2 different segments, 2 different straight arms, and then continue with your suturing. So this is your initial repair which you're going to do. So let's stop for remaining thing. I just wanted to show the initial suture. Again, here the initial suture will be at the corneoscleral limbus. So again, we have to be very particular about it. Again, here the stitches has to be very particular. You have to kind of make sure that the wound edges are clean, as we have discussed. And then after that, put the stitches at the end of the limbus. So here again, these are all very old videos, not necessarily the titanium instruments are there. So yeah, I think you can see the limbus have to be identified and the 2 ends of the limbus need to be closed. So once again, in a wound, please do that. And feel free to comment or add anything at any stage, anyone. Okay, then we go to wound alignment. Once again, you will see this kind of a zigzag wound. You convert into different segments so that you have this segments, and then you divide and then you continue with the suture. So you divide it actually into the 3 segments, and then you continued with the suturing of it. So likewise, other wound also you need to align it properly so that it is done in the most systematic way. So again, some of you will feel the videos are very basic and all, but I think it is important that sometimes it is better to revisit some of this video. This is another thing which I've seen in some of the videos is some of the surgical cases is that there can be retraction of the scleral edges of the lips. So it can go turn inside. So to kind of make sure that you retract it outside and then do it in a proper way so that you get the edges right. So once again, this is again a very basic principle which we need to remember. Otherwise, you will end up causing a lot of astigmatism and sometimes the wound leak and all kind of problems there. So you have to get some interning of the scleral lips, but not too much like you're suturing on the surface of the sclera. So those things you have to take into consideration while repairing the scleral repair. Now, this is the interesting thing that you have to pulling and not pushing so that you don't cause more damage. So you just gently pull, but don't try and cause more trauma. But something which I really wanted to show to you is a traumatic repair. You're just injecting and then you are just causing more trauma. So you have to kind of make sure that you don't cause more trauma. And this is not the case. You have to kind of use a side port or another paracentesis to inject a viscoelastic, but the surgeon continued to do it from there, causing more prolapse of the intraocular content. But here you see the beautiful video where he has taken a side port and trying to reposition the intraocular contents so that he can suture the corneal wound properly. So again, very basic thing, and then you have to remember. Then anterior chamber maneuvering. This is where one need to be very particular. This is a long video. I'll just come to that once the limbal wound is sutured. So the surgeon is trying to kind of the repair, and in the meantime, he's trying to manipulate to remove hyphema. You can see the hyphema is removed, but he's still manipulating, resulting sometimes in more damage. Where after a certain thing, he continued to do, and then there was a lot of prolapse of the intraocular content. So you have to be sometimes very careful is how you manipulate the intraocular content here in this particular step of the surgery. So this is something which we also need to remember is the recti need to be also hooked in certain cases. And this is a proper technique where the recti muscle is properly hooked. And sometimes you might need to repair, use it for wound exploration. But a lot of times you might end up causing more trauma by going inside the scleral wound if there is there. So you have to be very careful. You're not going into the scleral wound, but you are just under the rectus. Now, this is an interesting video and really very painful to watch. So the surgeon has put a traction suture. I don't know why. And then you cause this retraction by causing the intraocular tissue content to be prolapsed out. So really not the best idea. And this is again worst. You got this prolapse of the iris tissue. So I like to show this always is then you cutting. You cut, you see what will happen. You cut. You just be careful. Sometimes it still happens. So it just causes suprachoroidal or expulsive. So just wanted to show you some of the cases and hopefully that will give you an idea about what the books were trying to teach and why these books can be important. We'll go back again to the same thing. Is why this past lesson, why the lessons from the mentors, why the lessons from the teachers are important. So I've attended quite a lot of workshops with Farrington. He's a fantastic teacher who really holds hand and then try and teach. So I think what I urge KSOS and even AIOS to do some wet lab courses on ocular trauma, wherein we can continue to train so that we can salvage some of the eyes which possibly can be there. And that is a lesson which I learned from this thing. Now, I like this topic of controversies because trauma is one field which is not without controversies. And if you don't have controversies, you cannot move forward in science. So this is some of the controversies which we published, and something it is important if any researcher is there, is sometimes we go blindly with what is written in the book. So as simple as that zone 3 injury, and every time people write zone 3 injury is poor and zone 2 injury is okay. But have you ever thought that zone 2 injury is at 5 millimeter behind the limbus and beyond 5 millimeter is zone 3? I asked Farrington, why this magical number of 5 millimeter? Why not 6? Why not 4.5? So I tried, he don't have an answer also for my thing. Then I looked into Duke Adler's book, which says that recti insertion is at a different place, annulus of Xene is a different place. It is not at 5 millimeter. So I try to move that zone 3 to that, and then I created zone 3 into original zone 3 and then the zone 3 behind where I wanted. So you know what interesting in the case series which we published, we managed to see that if it is behind the recti insertion, the outcome is very poor. Whereas if it is anterior to recti insertion and still within that zone 3 of the original one, the outcome is still good. So why not we classify based on the prognostic? So again, a take-home message here is that when you come up with a prognostic classification, there should be some practical significance of it. So something I am still not able to kind of very clearly understood, but in our latest publication, we did manage to convince that zone 3 should be at the recti insertion. Again, there was a 8-ball hyphema, but there is nothing like. I don't play snooker and pools and all, but you see, you can check all the balls of hyphema. There is nothing like a black ball, because the black ball is the hyphema, and if you see, the darkest hyphema is still brown color, and then the other ball is the red color. So why again those controversies? So again, something simple, but I looked into the literature trying to see who was the person who coined. So in 1957, some surgeon coined the word called as a 8-ball hyphema. I'm still surprised why he called it a 8-ball or hyphema and all, where there is nothing like a 8-ball there, but maybe something again there. So when we get these controversies, when you think the questions are arising, which you are not very comfortable with it, you start doing a research, and this is where the current situation is that. And this current situation allows us to work together using an online platform. So we created this online platform called as iGates, International Globe and Adnexal Epidemiology Study in 2016. And it's been 10 years. It's been doing wonderfully well, where different peoples got connected and everyone is working together to enter data, and then we are able to generate multiple results using this collaborative platform. So it is very, very important that as we move forward, we all need to work together, particularly in this field, which is relatively rare and people are not that interested. So we need to get the like-minded. You can see the list of authors there, but there are more number of people who are contributing. Particularly, I like to mention about Dr. Giridhar. I don't know whether he's there on the call, but he himself, from a single center from Cochin, has contributed more than 2,000 cases to this iGates registry. You can imagine a center in Cochin, Giridhar Eye Institute has contributed 2,000, and even Dr. Chitranjan and many other people have contributed quite a number of cases. So this is where we can build up our knowledge and remove some of these controversies which has been existing, including the controversies related to terminology and all. So this is where I can say the iGates is an online international multi-center database for ophthalmic trauma, and it becomes a unique signature in the field of trauma. So this is how we move the research forward, and this is what we want to do. Now, when you want to move it forward, remember one thing, we are all occupied with our busy clinic and all. What you need is the power of youth. I always say, don't underestimate that. So these are all the young folks who have been working very hard. He was a year 1 medical student or year 3 medical student when he started working on and published a paper which got a best prize in the APOTS meeting in Kuala Lumpur, Malaysia. Kuala Lumpur, Malaysia, in 2019 or 2020. And now he's a resident in ophthalmology, and hopefully he will take up ophthalmic trauma as one of these hospitals. So we need to kind of work with them. So there is a lot of youth people. Anadi Khatri, you can see on the call, stalwart from Nepal. Grant Justine, who visited me, he was in Arvind Eye Hospital, and he visited me with Nepal for the first time. Now he has become the president of American Society of Ophthalmic Trauma. At that time, he was just a resident. You can imagine, if you pull these people together, he got super excited when he saw the different presentation of trauma and all. So this was in Nepal, in Kathmandu, in Telganga, with Dr. Eli Pradhan guiding them. So you need to get all these young people. So identify the people around you, identify the residents and medical student who can be there, so that you can move forward this field of ophthalmic trauma forward. Now, this is the infrastructure which you want to do, because you set up a hospital, you get the manpower. So we got iGates, we got the youth, we got the experience of people like Feringpoon and everyone. So that's all there. Now, when it comes to the analysis or the next steps, so is trauma all about AI? Definitely not, maybe, but let's go into the details about it. So where do the future of ophthalmic trauma lies? So this is something my favorite slide, and I really I spent time about identifying what are the 9 focused areas if I have been given a chance to promote this field. So therefore, I keep talking, and I hopefully the leadership here can take up this in a more constructive way in a forward. So one is we need to identify, brand the trauma. I'll tell you how. We need to continue to collaborate. We need to set up international registry like ocular trauma registries or global general trauma registry. Fellowships and education in the field of ophthalmic trauma need to be created, which already has been there. AI tools, which we'll talk about it. Polytrauma care, damage control ophthalmology, regenerative medicine, artificial vision. So quickly, let me share about it. Now you see this brand recognition. So these are the 2 top hospitals. You look into the subspecialties. Trauma does not feature there. Doesn't it hurt? It hurts me. So because I'm a trauma surgeon, and it's nothing there. So you find it's been so many years for me in Singapore, I'm still not able to convince that we should have an ophthalmic trauma unit for different reasons. So no trauma unit. Went to American Academy of Ophthalmology in 2022, morning 6 a.m., subspecialty day, cornea, glaucoma, oculofacial, pediatrics, refractive surgery. You got refractive surgery as well, see, because you get money. Retina, uveitis, no trauma. I did a Photoshop. I typed myself. I said, one day we will get it. Hopefully we'll get it. So these are the things which you can try, and hopefully someone from AO is watching this and they can try and insert that ophthalmic trauma one day in their course. You look into the BCSC series. So there are these 13 series of it: optics, pathology, neuro-ophthalm, pediatric ophthalmology, oculofacial plastic, cornea, uveitis, glaucoma, lens cataract, retina vitreous, refractive surgery, BCSC. It's like a Bible, right? We don't have trauma. So we've been talking to AO, and I think recently they published a section 14, which is ophthalmic trauma, led by American Society of Ophthalmic Trauma group. But I think finally, after a lot of dialogue with them for past 7 to 8 years, it has been published so that it becomes like a handy book for the trauma in this particular field. So this is about how you want to brand, how you want to kind of do that thing there. So we can be the social media influencer or whatever way you want to do it, you can just brand that trauma. Now it's about the collaboration. So we started collaborating with all different societies. So we were the first one, thanks to Dr. Ganga and all the team, to again reignite the fire in American Society of Ophthalmic Trauma, which was almost dying. And then we got them together. Now they are doing wonderful job, even better than International Society of Ocular Trauma. And but that was in AO 2019 in San Francisco when and it happened. And then we got all these leaders of trauma together so that we all can collaborate together, and collaboration with different societies on different initiatives over a period of year that has led to this particular results, wherein you can get a map like COVID map. So we really need a tracker. So when we talk about Digital India, can Digital India, through the platform of AIOS, create a tracker like this thing, where every single trauma is reported to AIOS registry? Happy to work with them. And any day you can just see what's happening. So in COVID time, we were all watching how many things are happening. So we really want to see that statistic, because that can be the first wake up call. So if you are going to talk to government about any protective things, any regulatory thing, you need to have this dashboard. So can we create something like that so that we can really identify how much trauma is happening in Kerala versus any other state in India, and then only we can make it happen and bring in a change. Now, eye injury registry I've spoken about. We need to kind of understand how we can create. So this is my kind of a vision wherein different people come on board, and we have this registry, which is just not data collection, but a final platform to disseminate the knowledge related to the field of trauma. And it can be really big, and it can continue to work in a very important way. So this is just my roadmap or my skeleton idea about how this registry can perform, wherein we bring in different people. Now, I've spoken briefly about the fellowships or ophthalmic trauma. So this is my kind of a blueprint about how such a trauma center should be created. So I believe every city in India should have at least one dedicated ophthalmic trauma unit so that the patient do not get this outcome. So you should have to have iGates registry, and in that you have to have a registry, whatever way, trauma registry, and then all the patient of trauma should come there, and after that it should be triage. So something like that need to be created, a skeleton, so that it can be moved forward. And of course, the advocacy in the terms of this photographs, and I'm sure all the societies do that. So we are happy to again work with AIOS to create this posters, which can be disseminated at the right time, whether it is come at Diwali time or any other time, wherein using this, we can then prevent trauma. So such an initiative will be quite helpful, whether it's KSOS or AIOS and or OTSI, so that we can all work and then prevent some of the trauma. I'm not saying that we'll be able to prevent completely, because we do know that even cigarette factories has that tobacco thing and everything written, but people do still take tobacco, even though it's known that it will cause oral cancer. But at least we can bring in some change. Maybe one eye can be saved. So for me, the target is, can we save one eye by doing this thing? Now, this is the last topic. I think there are other, but I want to spend a little time on this AI tools. So I'll quickly jump to the last part of the talk, which is a separate one on the AI. I think, is it the correct one? Yeah, correct. Okay, sorry for this. Okay, so I'm going to talk about the trauma should not be left behind. So I'm going to quickly talk about why we need AI in trauma. So first of all, we need to identify the challenges in the field of trauma. So number one challenge is the delayed diagnosis and treatment, lack of specialized equipment, lack of expertise. complex nature of injuries and multidisciplinary collaboration, but there are more challenges. We have challenges related to patient compliance, complications, limited expertise, resource constraint, patient communication barriers. There are quite a number of challenges. Can we use AI to remove some of those listed challenges? So this is just some of the many challenges which I have kind of listed down here, but hopefully we can use AI to address some, if not all, the challenges. So has AI been used in the field of trauma? Yes. The answer is yes. People have used different decision tools like that. So this is where different applications of AI in the field of ophthalmology has been spanned out. But let's talk about the specific use of AI in ophthalmic trauma, how we can do it. So first is creating a database and then using it as a registry to generate the AI model. So we have this platform, and then we applied machine learning platform. So applied AI machine learning. Now, machine learning was developed to do a predictive analytics. We were able to predict the outcome in different forms. What will be final best corrected visual acuity based on different factors which can affect final best corrected visual acuity. So this is a model which looks like GLMNet, which paper got rejected recently, but we'll continue to try and publish it in another journal. So in this figure, what it shows that what are the different factors which can affect positively or negatively the outcome. So if we know this factor, we might be able to address those factors and come up with a new ocular trauma score and help our patient in a better way. So I believe this is where AI can put into factors all the different layers of the eye and understand which layers get affected when, so that it will put into the proper context. And accordingly, we will be on top of our game to help and do that surgical repair, so that if I get a patient with a very high risk, I might get a senior surgeon to operate. If I get a patient with a relatively low risk and a good outcome, I might get a resident to operate. So you can try it, you can come up with those different things, but provided we know what are the risk factors. So that's one use case, how the AI can start infiltrating into the field of ophthalmic trauma. Second is we created a chatbot. This is a modified ChatGPT. So you can, all of you can use it, aitrauma.com. So created by myself and a student from US. So what we did is using the large language model, when the ChatGPT started, we modified it using called as a technology called as a RAG. And this is now available. So you can just play it and you can put in the question, what should I do if I have foreign body in my eye? I am specialized in discussing ocular trauma. I'm going to do not rub your eye and all those things. Do not blink. So you get some kind of answer. So this is a patient who is asking, but you can have an expert. So where is this source coming from? So the source has been coming from book of Farrington, which I just shown. So it is difficult for you to pull up a book, but the book can be converted. So we got all the copyright issues resolved, and then we put in the book after approval from Farrington to then get a source. So the difference between this and the regular ChatGPT is that it comes from a trusted reference, not hallucinating or anything. So it is a curated list of references. So the same thing, physician can use it. This is where you get this thing, and then you get a physician who can address the questions there. In case if you have any doubt and you want to refer to Farrington book, you can just do that. So this is where a ChatGPT or a generative AI or a large language model has been modified. Okay. So that's the use case number 2 of AI in trauma. So the last one. So Dr. Sujit will just finish it in another 5 minutes or so.
No issues.
The last question is the federated learning. Now, this concept is coming up in a big way, the federated learning. Now, what is this concept of federated learning, and something which will happen, going to happen soon? So federated learning is about deploying the model to the places where there is a data. What do I mean by that? So I don't know whether Dr. Santi from Indonesia is on the call, or there are other couple of people where we have deployed eye gates. So let's say if Kerala State Ophthalmic Society or any of the centers in India, they want eye gates to be there, but they don't want to transfer the data because of Indian government regulations. So the model of eye gates can come to that particular center. So this is the central eye gates, which is housed in Singapore. It can travel. So the eye gates can go there in those centers and get localized there. Okay. So it can go to center 1, center 2, center 3. The data will be hosted on the local server. It will not be hosted on the cloud. So at no stage, Singapore will be having access to this data. So you will be able to use all the capabilities of the platform, but at the same time, the data is not at risk to go anywhere in the cloud or to your collaborators outside. Now, how do you collaborate there? So you get your data locally. We will provide you with the codes which will run on the program, and you can analyze your codes and all there, everything. And then when the results are generated, which is a pulled results, your results, let's say you've got 200 male, 500 female, and whatever other factors are there, that results you can share it with the data center with Singapore, for example. So sharing the results is not a problem with anyone, but sharing the data is a problem. So when you share the results, so it should be okay. And we then put the results here. Okay. Back here, and then you can do all the pool data analysis, or you call it as a meta analysis, so that we can use that results. But at the same time, you can use your results locally. So that can help elevate the thing in a big way. Of course, we all know about telemedicine. It has been used for past many years, but now with the AI thing, it is going to still come up in a big way. So this is last, but not really the AI, but I just thought technology, how it is going to be helping. So last bit, the challenges of using AI, we do all understand, all of us, that there is a privacy issue. Also, this is a black box phenomenon. We are not yet ready to explain why an AI give a result what it gives. We might have to take it with a pinch of salt, the trust in the AI models. And the cost can be a prohibitory factor, because sometimes you start with something and then in the end you will see your bill going crazy. So I think quite a lot, and the patients are not going to pay. Who is going to foot the bill for those AI? So while you get excited with this novel technology, at the same time, you also have to understand the flip side of it. And these are all some of the real concerns, which I always say. So I will say at this stage, we are not yet ready in healthcare setting. We still have to work with our wisdom and our experience. So do that. And hopefully tomorrow's world will have more better idea about all trustworthy AI. So this is a word which I like to use, and it might help eventually where Indian government or a global government or WHO has given a regulatory compliance, and it is safe and secure, privacy is there, robust infrastructure, everything is just perfect, And I'm not going to get into all these things, but I just wanted to kind of end my talk by saying that eye injuries can be prevented. So we don't have to be part of the game, and hopefully we can all work together to prevent this thing. So my final line is saying that I will rather be jobless rather than to be a busy ocular trauma surgeon. So with that, I like to thank KSOS for giving me the opportunity to share my perspective on past, present, and future. And hopefully we can pick it up some of this thing, and happy to answer some standard questions related to clinical management as well as research related trauma. Thank you very much for the patience.
Thank you, sir. That was an incredibly insightful and comprehensive overview, and it is really thought-provoking, especially challenging the conventional boundaries in the management and previous classification systems. So I would like to begin my discussion by exploring some of these perspectives further. My first question is regarding iGates. So with this large international database like iGates, what are the new insights that we learned regarding the prognostication in predicting the visual outcome in ocular trauma that were not evident earlier?
Very good question, and I hope I have a correct answer to you. So mostly we were aware that RAPD is a very important predictor of the outcome, and we always used to say if RAPD is there. So that is one thing which has come up. The RAPD by itself is not the sole predictor, because there are reversible causes of RAPD, and once you remove those hyphema and other causes like retinal detachment, that can be taken care of. Second thing which we learned from the eye gates is the timing of the repair, and that has always been the issue. So earlier repair is always better. And now whether it is within 24 hours, 72 hours, we are not quite sure about it because of the data and the longitudinal outcome. So we do know that it is there. The second thing we also try to identify whether is based on the surgeon's experience and all. So wherever there are senior surgeons involved with more experience, that is probably better. I'm sure we all know that, but sometimes it is not followed. So we wanted to bring up with the scientific evidence. I can see Dr. Susank here on the call also, who has done some of the amazing work related to fireworks and all, and Dr. Dhanasri also together, I think, and Chitranjan. So that fireworks data was quite crucial, and we were able to show that how damaging the fireworks can be in a pool data analysis, and that we were able to present it to through Dr. Purendra Basin and Dr. Grover's effort. We were present, and OTSI efforts, of course. We presented it to National Human Rights Commission in 2022, in August 2022. And that year, they released a white paper because that was based on the data that the fireworks can be harmful. And 26 states have to cut down the use or moderate the use of firecracker. And that year, the statistics of firecracker related eye injuries came down significantly. But that was only 1 year. So it was through the retired Justice Mr. Arun Mishra, and that was through the contact of Dr. Purendra Basin. And we hope we can make similar efforts happen. So this data will allow us to help us regulatory thing, even if I believe it might not help in the clinical management. The other thing which I'll say that which we are coming up with that and is called as IGATES index. So IGATES index, this is based on the real life data, the data which is there. So what we have done is we identified the key factors based on the data that which can be taking part in the final outcome. So we do know the factors from the ocular trauma score, but ocular trauma score by itself is not complete. We wanted to introduce another factor. So all those factors put together forms an IGATES index. Now, I haven't gotten a mathematician yet who can then give a weighted score, but I'm still working on it, wherein we can get a final output, wherein we can say that IGATE index of 1 to 5 is a poor outcome, 5 to 10 is a good outcome, and probably 10 to 15 is the best outcome, something like that. So we are still trying to work out that weighted score, but what we got is the factors. What we don't have right now is the weights, but we are hoping that we'll be able to cross that line. And that will give us a handy tool on your palm top or on your mobile phone, wherein a patient comes in, you just click, click, click. So it is a picture-based tool, and you just click, 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 click. That's it within 30 seconds, and you will get outcome and which you can share with that. So those are some lessons I will learn, but by and large, I will not say it has changed in the way the clinical management which we have been doing.
Yeah, that's interesting, sir. And I would like to know the limitations of such large international global data. And when we are considering into real world statistics or situations, when we are applying to individual patient management, there will be clinical variations, difference in the healthcare system, difference in the data provided by different clinicians. So how we can apply for individualized patient care?
Very, very good question. I am really impressed with that, but I'll take a step back even before I come to that. So take it with a pinch of salt. Most of the retrospective studies or the studies published on the clinical research comes with their own biases. So we are trying to publish one of these papers related to data challenges, wherein the data is incomplete, the quality of data is poor, despite whatever training we do. And I think we try to be controlling as much quality as we can, but when we try to do this data analysis, it's still very means it's just not it's very contaminated. So you really want to kind of identify how do you do it, because this is not incentivized. You are not having a proper research person or a fellow who is entering the data or anything like that. So where we see the data quality is not there, and then a lot of time the longitudinal data is not recorded and all, and that is only the baseline data. So one paper which Dr. Chitranjan and one of the students from IIT work is on only on the baseline. How can you predict the outcome? But it was all not validated with the prospective data, so or the follow-up data, longitudinal data. So that those are the inbuilt challenges. You can create a beautiful tool, but if you don't have a proper dedicated mechanism to enter into that data, I think we'll be still struggling. So the solution to that, only thing which I can think, and if it is possible, integrating that into your electronic medical record. So if a patient of ocular trauma comes, automatically a chart should come up, IGATES or whatever ocular trauma registry, and then you should get all the questions whichever are listed, because this is based on whatever we want to identify. So that should become a part of a clinical tool. So this is what I have gathered information. Now, coming back to your question, it is also related to this only. So let's say there is a different practice in North India and different practice in South India, or different practice within different states in South India. I think we are not yet there to tell about differences in different patterns and outcomes and all. We are trying to do something on the uveitis, in that field, wherein based on the different regions, you can give a different treatment or different things like that. But unfortunately for trauma, we haven't recorded that geographic location, and will it matter? Only thing which we have two data is the age and the gender. But hopefully we can look into that and whether we'll say. It comes to the individual management, I will say in trauma, I think it is going to be tricky to say that based on a certain configuration of a wound, you will be able to customize your treatment plan and do that. So I think it still will be gone by very broad principles at this stage, rather than a very individual precision medicine, which we are trying to bring again in uveitis, where we believe each patient is unique. But in trauma, you just categorize that posterior scleral wound has to be dealt in this way. So you can't say that posterior scleral wound in a male patient will be dealt in a different way, or in a younger patient will be a different way. So we might come up with those guidelines, but I think we are not yet ready. We are not yet ready.
Thank you, sir. I would like to invite our panelists to share their thoughts. Dr. Bhangli, sir, what is your opinion regarding the lack of standardization in the management of various aspects of ocular trauma?
Yeah, I think the basic fault starts right from the training of our residents to everything. If you look at in general, the perspective wherever we are working in, it is the first year resident or a second or a final year resident who usually handles the trauma. And as shared by a few of the pictures of Dr. Rupesh during his presentation, we could see an overriding wound or an incompletely, improperly sutured wounds. And if we leave the job to the residents or the primary caregiver, who are usually the residents in most of the places, the standardization of data is quite far off. So very rightly said by Dr. Rupesh, we are quite away from it, at least in our country. I don't know his experience with other Asia Pacific countries, who is the first caregiver in a trauma. I think Rupesh would be better. But in India, this is the challenge.
Yeah, so I think it's still a challenge, which I thought, I think we can ask also Dr. Susank. He's doing his fellowship in trauma in Hopkins, so he can share about his experience. But I can tell definitely about what we are doing it in Singapore. So when I came here, it is a resident or a registrar, which is not yet a consultant, like our residency. So who is doing MS? So they handle the trauma here. Consultant is on call. What I started seeing is that sometimes the consultant is there, sometimes it is not there, though they are supposed to be there. So it is more or less like there. And then I asked my first resident. So my first case was in 2009, 2010, and that was a no light perception eye, where I was just on call as a standby registrar to medical officer, and was asked that I was to be eviscerated or enucleated according to the no light perception. I said, no, let's repair. And we repaired. Next day, light was perception of light. So everyone was surprised, and it was quite a posterior scleral wound and all we managed to repair. So sometimes it does happen that you don't have that guidance and experience. So here again, we are struggling. And I think most of the places in the world, we are struggling. I don't know what does Susank feel about US system, Susank? Hopkins or
Hello.
US?
Yes, sir. Am I audible?
Yes.
So great talk, Dr. Rupesh. As usual, learned so many things. So I'm Dr. Sushank, Cornea consultant from LV Prasad Eye Institute, and currently I'm doing my trauma fellowship from Wilmer Eye Institute, Johns Hopkins University. So what my experience or what I'm observing here, unlike in India, where all residents or the trauma cases are last cases and they are neglected towards the end of the day, and any resident or any newcomer is allowed to do that case. Here the scenario is little different. There is one post called chief of the trauma center, and there is one post above that is a director of trauma center. So director of trauma center monitors all cases, and the chief of the trauma center is the person who finished their fellowship, including specialty fellowship and residency, and they are taking care of all trauma cases. They are training their resident as if we are training them in cataract surgery. So sometimes I have seen the last trauma case, which was done for almost 4.5 to 5 hours. and it was done by the chief. Wonderfully, he removed intraocular foreign body with polytrauma, and he managed it very well. And patient is still under observation, and we are hoping to get some better outcome. So I think we need to change the pattern of training in our country too. Like we should also train our residents and through wet labs. We should train them in basic suturings, which is less likely happening in most of the training institutes in our country. So maybe we just need to change that pattern of training, which will help us to get better outcomes in trauma patients. So the gross difference I'm seeing here, training is in reverse way. At our places, it's from first year, second year resident. Here it's coming directly from the director and chief of the trauma center. So creating a huge difference in outcomes. Thank you.
I
Thank you,
think I
Dr.
can highlight one more thing which Rupesh brought out about the case which he shared in the OT when he joined, that it was a no PL case. So I think the general audience who are watching this particular episode, remember, no PL is not an indication of, rather I should say, in a case of a trauma, it should not be the reason for enucleation or evisceration. Always give a benefit of repair even in a no PLIs, should be a strong, loud message which should go across the audience.
Yeah, I would like to ask Dr. Biju John sir regarding the PG training perspective. So what are the common mistakes that residents do regularly in managing the trauma? First, in assessing the trauma, how we can teach them a stepwise approach in an emergency situation and especially in a resource constrained settings.
Can I just make one comment for Dr. Biju make a comment about it? I just wanted to kind of continue on what Dr. Shashank mentioned about the wet lab. So I'm sure there are many wet labs which happen. So one wet lab which I witnessed there in Vijayawada, and where Dr. Shashank is working, and they have a wonderful wet lab every year in January as a part of trauma workshop. So next year, I think it will be on 9th and 10th January there in 2027. So I think it's a wonderful one. They really gives a very hands-on kind of thing there. So I think that's something which we can identify. And if it is possible, we can start replicating in all the states in India, including at all India level also. So just thought, sorry, Dr. Biju, I interrupted. So sorry.
Yeah, okay. I enjoyed your presentation really well. I think it's a wonderful presentation. It opened a lot of new avenues, sort of made us open our eyes into the way the future of trauma would be. And particularly the part that is stressed upon the importance of the training of the junior ophthalmologist and the residents. So we need to have some sort of uniformity. As you rightly said, ocular trauma needs to be given its rightful place of importance. And I think to answer Dr. Aparna's question, first of all, I think listening to this, we are in a sort of a better place because we are not actually having the fellowships here. We are only having postgraduate students. So here, most of our traumas, especially the open glove injuries, are all generally taken up by the consultants only. And we will probably give a few steps like suturing to the residents. So that is the way the training is going on here. So it is always a supervised suturing or supervised management by the trainee. They don't get to actually do it on their own, generally. And only the final year postgraduate students will be actually given probably a full case like that. But that also the cases that we feel will be okay for them, not the complicated cases. So I think as most of the traumas get, the full attention of the consultants. And so generally the mistakes that I have found from the postgraduate student, that is mainly in the diagnosis part. For example, mistaking, because they are of course the first respondents in the casualty, and mistaking an open glove injury for actually a closed glove injury in order to actually fail to detect the full thickness wound somewhere, which might be hidden under a rectus muscle or hidden under a conjunctival hematoma, not doing the exploration. For example, I still remember a few cases. One, it was in the morning during the rounds, one case which was presented to me as a closed glove injury with vitreous hemorrhage. So in slit lamp examination, what we could say that still I talk about it as the standing lash side, because I could actually see a lash which was actually standing upside down on the sclera. So which is seeing upside down means that part of it is inside, otherwise it won't stand upright like that. So we would immediately ask the concerned to take the patient for explanation. So we found that it was a full thickness wound, and it didn't actually end up there. The ultrasound actually revealed there's a track which went all around, all the way up to the retina. So we had to actually do a vitrectomy because there was an elevation there. It was found that actually there was some sort of a trauma, which was an object which has actually gone in, penetrated and gone up to the retina and came back. So it was like that. So it was a small lash, which almost seemed like a close glove injury. Same thing which happens in some of these foreign bodies, which sort of select the pars plana route or even the posterior route to actually enter. So leaving no trace of its entry in the anterior part. These are some of the mistakes which they generally make. And and another case which I remember was that one case which was actually following trauma, following injury, following the primary repair. The case was brought for VR intervention. So this was a case which I could actually see the retinal detachment even without indirect, because the retina was practically touching the lens there. So basically, so I could do an indirect, and I was surprised. No, it was the first time that I was seeing actually an open scleral wound through an indirect ophthalmoscope. So there was a lot of the posterior part which was still remaining unsutured. So that is again another thing which I wanted. The posterior action sometimes get missed. So later we took it up again, and it was actually extending under the rectus muscle to so far posteriorly. So that is something which I think could not have been repaired in the primary repair at all, because it required a squint surgeon to actually disinsert the muscle, repair it back, and after that it was again taken up for the VR intervention. So trauma is really interesting, a lot of different experiences. And intraocular foreign body is another situation where you have a lot of experience, like their varied experiences. And I also would like to actually, one of the, I think, saw a chat message regarding the antibiotic protocol in the open glove injuries. So I would actually like to ask the panelists also, is there any standard antibiotic protocol, which means that which are the cases that you routinely give intravitreal antibiotics in an open glove trauma?
So I think, thanks. If the question is to me, I will say country-wise it depend. Typically we give broad spectrum antibiotics, and again intravenous is something which we all try and give it systemically. Ciprofloxacin is the drug of choice typically which we want to give, and post repair. Some people also give intravitreally and all, but intracamerally, but not a very standard practice. Antibiotic was topical antibiotic is of course given after the globe is repaired, and again a broad spectrum antibiotic is given. Typically in Singapore we give Kefta, Zenta both, so that both the gram negative and gram positive are covered. I'm sure Shushank and Dr. Chitranjan on the call also will be able to kind of share what has been given there in India. About the steroids, so very interestingly in Singapore, they are not very keen to give topical steroid post repair immediately, which we used to give it. I used to give it also in India. And the thing is that there can be a risk of infection. So they're very slow. They will start with 2 times a day, then 4 times a day slowly, and then only will make it 3 hourly. I used to give it like 1 hourly from the day 1 of the post repair. So I don't know what is right or wrong in this context. Maybe I will still say we have to be just a bit watchful if it is not resulting into some kind of a corneal infections and all. So I will say a bit watchful. Systemic steroids, again not a big fan unless there is extensive choroidal detachment and all, but only if trauma is there, even if it's very extensive. So not required systemic corticosteroids for any kind of I think mostly topical steroids and antibiotics will take care of it there. So that's about my experience. I don't know whether anyone on the group has different experience they want to share. Chitranjan?
Yes, sir. Thanks, sir. Thanks for the question. So I think it's regarding the antibiotic prophylaxis for open globe injuries for endophthalmitis. So as you rightly told, we can have systemic antibiotics or topical antibiotics or intravitreal antibiotics. And I can clearly remember there is a Delphi study going on, because as you rightly told, there is no definite protocol for this prevention. And systemic antibiotics, there are many studies, but as you told, ciprofloxacin group has been found to be having some upper hand, but nothing is conclusive in prevention of endophthalmitis. Coming to intravitreal antibiotic, like during surgery, during the primary globe repair, that is having some evidence of prevention of endophthalmitis, but again, that is used as per the discretion of the operating surgeon. Regarding topical antibiotics, there are again two schools of thought. Some people say that it will prevent infection, but others are skeptical about the intraocular penetration of the antibiotic and causing toxicity, because you don't know what percent is going inside. So better thing will be to kind of suture the or kind of repair the globe. That will be having more value in prevention of infection rather than just relying on antibiotics. That's what we all know. But yes, we are coming up with Delphi model from all the senior trauma specialists, and also the systematic review and meta-analysis on these studies can answer it better. Thanks, sir.
Thank you, Dr. Chittaranjan, for bailing me out of this difficult question. Thank you.
So I would like to ask Prashant sir. Okay.
Out of this difficult question. End question our
Okay.
You are our guru, sir, Rupesh sir, in trauma.
Trauma, everyone has to pull in their knowledge.
Yes, sir.
Okay, I would like to ask Prashant sir regarding his previous statement regarding the enucleation. Even in severe trauma, we are not doing primary enucleation nowadays. And what are the situations where we are forced to do a primary enucleation rather than going for a conservative management?
I think I would say, even if it looks a very badly macerated eye, if you start making an effort to reconstruct and suture it to salvage the eye, many a times you are successful. So for me, even if it is a very irregular types of tears which are extending behind, I would definitely make an effort for 4 to 5 hours rather than enucleate primarily. And I think the fear of sympathetic ophthalmia is too highly ingrained in our brain. We need to relax from it. We have good immunosuppressives. As such, the incidence is quite less if you do suturing properly. And with the availability of good steroids, immunosuppressives, that should not be ever considered when you are considering a point of, trying to decide whether to salvage an eye or not. So even the most unsalvageable eye, if you start making an effort and spend time with it, you would be able to salvage surprisingly. At least an anatomical eye can be salvaged.
One other part besides this sympathetic ophthalmia, immunosuppressives and all those things is also, the patient, when you get the trauma, the family and their patient is panicking. And you go and then say, doctor says immediately, oh, enucleation. The family will be like, wow, is such a radical thing, But sometimes it is also for family bit of a moral building that the doctor did try it, even if the eye did not say, he tried to put in the best, because at least it's a psychological well-being of the, because removing eyes like itself, and I said that the only risk why you're removing is the sympathetic ophthalmia. Other than that, you're not gaining any big advantage. So I think we also take into consideration that part also. So it gives patient time to kind of understand that, hey, the team did put in efforts, but it just was very bad trauma, and therefore it still remained no light perception and all.
So based on the global database, what is the incidence of sympathetic ophthalmia nowadays in current scenario?
Though I'm co-author of that paper, but I think it is very less than 1%. I think I have to just check that paper which we published.
Not 1%, it should be 0.001.
0.1. Yeah, 0.01, but very less, very less, definitely. So we got that because we did a meta-analysis, and I might have to pull up that paper. Haven't remember the exact incidence of that, but yeah, it was very low.
Prashant, sir, can I ask a question?
Yes, please.
Even if it's a very low percentage, what is the medical legal implications if it happens, especially in our scenario, in Indian scenario, like in a very badly macerated eye, will a question rise later whether you could have removed it and saved the other eye?
Yeah. So I just managed to get that paper out. I'll just show that and I will answer your question of the medical legal, and it is a very important, and we'll get other opinion also. So as Dr. Prasant rightly said, 0.12% is a 95% confidence interval, also good. And this was based on the largest series which we published even in ophthalmology in 2024. So good to review this paper, and good, no evidence exists that primary use can reduce the risk of secondary sympathetic ophthalmia. So this is number one. So I think this also helps us in answering Dr. Sujit, your question also,
Exactly.
that this is a study which we can definitely produce in the court of law. Of if we really want to say that, hey, sympathetic ophthalmia preventing or not and all. So you can say that this study also did not show. And I think it does not stand that it medical legally someone says that I got it and all those things. So you can always say that one is the good documentation, wherein you say that the risk, all this thing has been defined. So very good documentation will helpful. Good communication and open communication with the patient will be helpful. And of course, after all this thing, documentation, communication, patient still goes to the court of law. So I think the statistics and all the other expert will be with you on saying that, unlike the previous, those famous cases there. But right now, I think it will be there because mostly people are aware that it's not that thing there, which is resulting sympathetic ophthalmia. And people have done it in the good faith. And though the risk of sympathetic ophthalmia has happened, which has resulted into the fellow good eye getting exudative RD and all kind of stuff. And then doctor tried to treat it with steroids, immunosuppressives and all, but still that eye also gone bad, the other eye also. You can't say that, and I don't think it will stand in the court of law. As far as I think, I don't know whether Dr. Bhawankule or anyone else has anything. And though I know one homework I've not done for Dr. Bhawankule, he's told me to come up with a good medical legal consent form for ARs, but haven't finished it. So I think he will say that better I say it upfront. Yeah.
Yeah, I think Sujit very truly said, as rightly said by Rupesh, the basic intention of us is to help rather than being under the fear of just medical legal thing. And these are usually, if you look at the trauma, they are young people. Even the cosmetic salvage of an eye is equally important to the eye for that patient. So a good communication, proper documentation, and above all, the latest literature has enough evidence which can help you out medico legally. Yes, sometimes the judiciary can be very unpredictable in Indian context, but to tell you truth, if I do about 60 plus surgeries of trauma in a year, I have not enucleated in last 28 years any eye.
I think it would be beneficial for all if the AIOs can come out with some sort of a guidelines here, because these sort of things will stand up in all courts. We can always say that this is our society, we go by the guidelines like that. So it would have been good.
Preferred practice patterns, I don't know from a society how much would it have. We have made it for endophthalmitis and all. Trauma is a good suggestion. I think it is our job of ARC committee. We would definitely look into it and we'll seek help from Rupesh and Sushank and all who are placed across. So we will be able to generate it. I think that's a nice suggestion. As a ARC chairman, I do take it and we will be ready with you for in a year.
So can you please share some practical tips in handling the intraocular foreign bodies, especially for the young surgeons in the initial part of their learning curve?
So that question goes to?
You only.
You only,
Okay.
sir.
So it depends upon intraocular foreign body, where is it placed, and the type of and the nature of the foreign bodies, frankly speaking. So if it is an organic type of a foreign body, which is likely to incite a reaction or lead to an infection, we should try to remove it as a primary procedure along with the primary repair, provided the primary wound is not in the visual axis. So as a vitreoretinal surgeon, if you have a wound of entry away from, if I get a central 3 to 4 millimeter, I do not have a very ragged edge, I close the wound and in a single go, I would be removing the foreign body if it is likely to incite an inflammation or an infection. For example, a mechanic who is working with a scooter, usually his foreign body is smeared with, that grease and all, whatever they call it. So it will be leading to infection, or an organic foreign body which has gone into the eye. Prudent to remove if possible, and if you can do a decent enough wound closure with a proper vitrectomy and a proper media allows. But yes, if the tear is in the central of the visual means in my vision, and even in spite of doing a pupillectomy and doing a lensectomy, I am not unlikely to have, then it is prudent that you just repair, and as early as possible, you get an opportunity of a media, you should remove the foreign body. I think I've just put it very grossly, but you have to really go case by case.
I think one more thing is that, many of these cases, intraocular foreign body, we get referred cases because the primary repairing surgeon, may not have access to the VR facilities, or a VR surgeon may not be there. In such cases, we always advocate that they do the primary repair and send after giving an intravitreal antibiotic or something.
And the intraocular foreign body I deal with is an anterior chamber intraocular foreign body. So I also say that is also intraocular, right? It is also in the anterior chamber. So sometimes I put it there. So the next day retina surgeon says, how come anterior segment surgeon is there? So I just write it in their intraocular foreign body. They see in the OT register, how come Rupesh has done that? I just put it there. It is, even if it's anterior chamber, it feels good that you have got an intraocular foreign body case against your name in the OT register. So anterior chamber foreign body, just to share some thoughts, and we don't speak about this topic. One of the under-recognized entity, and a lot of times based on the history of the trauma, the entry wound of the kind of foreign body, and sometimes you can get a tiny little iris hole also there, or you can get a localized traumatic cataract. You need to suspect, and when you suspect, you need to kind of check where the anterior chamber intraocular foreign body can be there, and it might be somewhere sitting in the angle. Sometimes it can be intralenticular, and sometimes it can be in the space between the iris and the lens. So if you are not watchful, that itself can result into cirrhosis and many other problems, and we need to be very careful with that thing. So I think it is important that keep a watch and make sure that you make a negative note about that there is no intraocular foreign body in the patient, in anterior chamber intraocular foreign body in the suspected cases. Of course, posterior chamber intraocular foreign body is a completely important topic, and then you will be watching out for it. But what is neglected is sometimes the anterior chamber body.
I think it would be prudent that we should always have a CT scan, or if not CT scan affordable, at least an X-ray plate from medical legal point of view whenever we have a nature of injury in the form of blast or a projectile foreign body.
Very
So
important.
it is always prudent from medical legal point of view, at least to have an X-ray plate.
Yeah.
So, being an oculoplastic surgeon, I always feel that this adnexal injuries are less represented in current classification system. And
Good.
what is your thoughts on that?
Yeah,
Do we have
that's
an do we go for an integrated classification system, integrating AI and imaging systems and ocular adnexal injuries also?
Yeah, no, very good. And as I said, we have included that in the iGates index,
Yeah, it is there.
and that is a very important thing. And we have to kind of include. Let me see whether I can pull up iGates index. So this is the iGates index, which I can just show it to you. And we are like trying to kind of finalize this thing, not yet ready. So you can have this male, female. So what we have done is a mechanism of trauma, just to kind of take a step back and then tell. So we have typically sharp, blunt, but a lot of times there is a mixed trauma. You don't know whether it is really this sharp. So sometimes there is a finger fist injury that can be a nail of the finger, or the some ring on the finger, which might have caused. So it might be penetrating with a blunt trauma, and also burn is not there in the original color. So we added this to new one, the mixed and all. And then there was a bite also, animal bite, which we tried to add. So again, open globe, closed globe, we kept the more or less the same. We just wanted to put in. And in the factor here, as you very rightly said, adnexal injury should be indicated. So we have indicated there, you can factor, but I don't have the weighted score. So this is a new thing which we learn from the trauma, is that adnexal injury is important. Even the lens injury, these three were already there. Endophthalmitis, RD, and RAPD for ocular trauma score. But this two has been added as a severity indicator. So you got the mechanism of trauma, open globe, closed globe. And then we also wanted to say trauma zone, and in where I introduced my new trauma zone of zone 3 and zone 3B, and additional remarks. And then that will allow you to generate a particular score. So we are hoping that we'll be able to generate, but from our data itself, we were able to say that if it's an adnexal injury, it will affect the outcome. Now, people ask me hypothesis about why adnexal injury, which is lid's orbit, has to be causing with a poorer outcome of the trauma. So whole concept there is that when the adnexal injury happens, which involves the lid and the orbit, the nature of the injury is sometimes very severe. And that severe thing causes more damage on the retina and the sclera and all. So the outcome automatically, so it is an indirect evidence of the severity of the injury, and therefore people say that it is there. We haven't, this is a hypothesis postulation. There is no mechanism studied as such and all, but I'm just proposing a reason, because of course it is a question where people will ask why lead injury has to be associated with the poorer outcome of a post-trauma, but just one of the possible factors.
Intraocular
Yeah.
pressure is also included in that, sir?
No, we haven't included the intraocular pressure, which is also very important. Closed globe injury, it is there. Open globe injury, we haven't included, and that is also one of the neglected factors. So in my controversies paper, I've written that intraocular pressure is been ignored. And again, the data which we collected did not had enough intraocular pressure for us to kind of make a statement. So that has come as one of the limitation. So if eventually we feel in open globe at some stage intraocular pressure need to be included. So this is going to be a dynamic tool. It's not going to be a very static one. So you might have 10 different variables which is present in 2026, but in 2027 there we might have 10 other variables.
So just out of curiosity, I just wanted to ask Yogesh sir regarding your journey. Like what are the challenges that you faced, and what is your advice to the youngsters who wanted to think, who wanted to break all these conventional boundaries?
So I think it has been a fun and learning. And first of all, I got very good mentors. Dr. Kandela madam is there, Dr. Pawanpul is there. So the journey started with them in Nagpur, and I think that was the best part of my journey, I will say. Of course, on the way, I met many mentors, but the initial days when we were hardly known, then these were there. And then eventually got friends like Sushank and Chitranjan and all. So I wish I can have that enthusiasm of 1% of what Sushank and Chitranjan have that. So they are brilliant and at the same time super trauma enthusiast and all. But looking at the career which I had, it was not very well received in the terms of the trauma, because not many people will like to do. So when I was a fellow in Shankar Nethralaya, I have used to have a pager number 023. Any patient of trauma comes, I have to go and attend to that patient. So again, then I will take that patient to ward and theater. So I was known for bad reasons that Dr. Agrawal will come, and I was called as RVA. RVA will come and then push sisters and nurses to admit, because that was the only thing which I was trying to push. And the surgeons will try and run away from me, because then I will catch hold of them for doing a repair. And 5 p.m. then the surgeon will change. They will try to kind of clock that until the time some of them will not show their face to me, because then I'll say, okay, we need to go for a repair. So that part was there. It was fun, but at the same time also where we saw that it was then when it comes to the repair, also I've seen different surgeons doing very differently. I used to be assisting all the trauma repairs till case number 72, when Dr. Ganga was there at 1:20 a.m. in the night. He said, "Have you repaired anything?" I said, "No." That was a young gentleman, 23-year-old Marwadi gentleman in Chennai. And he said, "Okay, corneal repair, 612 vision." He said, "Okay, you sit down and repair." He hold my hand at 1:30 a.m. in the night, and then he went through 5 or 6 sutures. So if we have people around like Dr. Ganga around, so I think who had at 1:30, he could have just finished the case in 5-10 minutes and then gone. But he sat down with me to go down. And after that, any surgeon will come in Shankar. They said, "Have you repaired?" I said, "Yeah, I've repaired one corneal." Then I will get all that cases. So we started doing that. It was going on well. Then when I came to Ganpati Nethralaya Jalna, after that trauma fellowship for 2 years, it was not a field which was acceptable, but I became the ocular trauma head, and every trauma case will come to us. And then we had to repair every of those trauma. So I will finish my cataract theater or OPD, and then we'll go and repair all the trauma. And every day, maybe sometime 4, sometime 5, I was a single person repairing, but did not have any knowledge about research. So done more than 1,000 cases that time in Ganpati Nethralaya by myself, but no fellowship, no training. Was trying to learn, but no. Came to LVP, different way. So Sushant, don't get me wrong. Cornea was repaired by anterior segment surgeon. If there is a scleral trauma, will be repaired by retina surgeon. If it's a lid trauma, oculoplasty. So one single patient will be repaired by 3 different fellows, and it will be the junior most fellow. So I was concerned. We raised concerns about the trauma goes to the last, And there was one of the concern brought up that cataract will go priority. So if the patient comes at 4 p.m., 5 p.m., it will go into the next day, last case in the thing. So those were the things which I have seen. Coming to Singapore, again, the trauma is not a recognized subspecialty. We tried to set up Dr. Ganga and myself ophthalmic trauma subspecialty. Not recognized. We haven't got 17 years. I'm still not able to set up an ophthalmic trauma unit. Only thing is that with the love of OTSI and APOTS, we are able to make some academic differences, able to inspire young folks and building up a community of 400 plus people through APOTS and big OTSI, where we contribute. And hopefully with that virtual kind of our group, virtual in the terms of everyone is doing different things, but like Dr. Bhavan Kule is so passionate about trauma. Dr. Khandelwal madam is also passionate about trauma. She's a glaucoma surgeon, cataract surgeon. Dr. Bhavan Kule is a retina and cataract surgeon, but they still do trauma. Dr. Susank can just spend time on the cornea, but he does. So we have people like that, but then there are other people also who can contribute more. So we have seen many things like that in my journey. What I want is more people to step up, and each hospital can have a cornea surgeon or a retina surgeon or oculoplasty, but with interest in trauma. So we need to identify. You cannot have a pure trauma surgeon. So you might have to get a cataract or someone, depending on each hospital. So if that can be done, that is something which I think will be helpful. But we don't know when trauma. So for me, trauma is still an orphan baby. And I will say in All India Society, when we used to present, it will be the last day, last meeting, last session. But now I see it is on the day 2 or day 3, and which is still attended very well, which is a big change which has happened at AIOS level. So trauma gets a center stage, which is happening. AO used to be like that. Only 9 presenters will be there. But now you go to AO courses, there are there. Dr. Khandelwal and I, we've taken courses where we have only presenters speaking to each other. But now you go there, people are talking to each other. So I think things are moving. ASOT happening wonderfully. I think next week, ASOT is there in Houston. They run wonderful workshop and they do fantastic job. One workshop happens in Germany by our president of ISOT. They do wonderful workshop in Berlin. One workshop, Marcus Collier leads it in this hospital, military hospital in US. I think Walter Reed Hospital. They do wonderful 4-day workshop, something which we need to all learn. So I think there are many things which I'm seeing happening, but I think we are doing now good progress, but I'm sure there is still a lot of journey to cross. So I hopefully we'll be able to do, but yeah, quite a lot of those emotional, I will say, things there with this journey. But for me, I will say I might not be doing actively the trauma repair as such, though I would have loved to. But I'm definitely involved in academic part of it in the terms of research and all. So I feel I just feel kind of blessed with all the collaborators and contributors and mentors and guide that they are able to kind of guide and support. So that one I want to thank. So I'm just representing the team, but all the hard work has been done by all the people who do the surgeries and all. Yeah.
That's
I
very
think
interesting.
Aparna, I will intrude here. This guy, Rupesh, is very humble, at the same time very shy. He has gone through a real struggle in establishing an ocular trauma, not only in India or in any institutes which he alluded to, but even in Singapore. I think his dream for trauma, his love for trauma is why he could get through that lows in his life. And I think he has a very strong partner in his life. Who is standing by him, and that is, I think he has not given due credit to her. So I think his wife. So that is it. He has really gone through a lot of struggle. Now he is in the top, but this message should go down to the other people, audience over there, younger people who are watching us. So it is not a rosy picture which reaching that top and making a mark for yourself.
So, as we are nearing to the end of the session, I would like to request a final comment from our panelists, starting from Dr. Biju, sir.
Yeah, I think coming to the end of a very fruitful session, I think there was a lot of takeaways. I think all of us who are watching, especially the youngsters, they got a way of how to go forward. Then what are the prospects in trauma? What are the importance of the learning this repair of trauma and to take it very seriously. So I think thank you, Dr. Rubesh, for guiding us through this interview.
Thank you.
Prashant, sir.
Well, I would just reiterate few things. Don't take trauma lightly. Yes, as a resident, because you are for a front runner when it comes to you are the first phase of emergency in any colleges. Just don't try to show it, because I, as a resident, used to see that I get the surgery done in the same night, so that as a resident I would get to repair it. But seriously, do respect that tissue. Take help of the seniors. Never inoculate an eye just because it is no perception of light. Always give an eye an opportunity to be salvaged.
So, can we take some questions from the audience? Anything to add further?
I think from my side, I think this is a message. We have other people as well.
I think the one question from Dr. Papa is there in the chat box. She's asking where we had a case of foveal injury with laser light used in stage show. Any experience
Yeah,
regarding that?
I had a patient recently who had they were suspecting some retinal dystrophy and all, and then they called me. I said, "What is the profession of that patient?" He was a labor in Singapore who used to work in this thing. So I asked him, "What do you do in the evening after your work is there?" He said, "They go to a bar and all, the pub and all." I said, "Do you go to the bar that does have these laser lights and all?" He said, "Yeah, that's quite frequent." I said, they were all planning to do ERG and all. So I said, "No, this looks like a laser injury because the kind of thing is there." So that was very recently I saw, and then the diagnosis completely changed. Vision was a little because it hit the fovea. It was there, and there is no proven treatment, but it was like looking like there was some edema around. We given a course of topical steroid. The patient was stable. There was still some of the damages. It was still showing on ampular grade certain problem, distorted lines and all, but mostly was okay. I think we do get laser related thing. I've seen the laser burns happening in the skin. Foveal injury, laser burns is not uncommon because this person is just sitting there and he just laser comes and hits his fovea, Yeah.
It is also something which I think the IOS need to take up, because these lasers are supposed to be safe, just like Papa was telling. Because I also had a few cases like this. At least two cases who had come after the DJ party. All the complaints are just they were actually looking at the DJ lights. But these lights are supposed to be safe for this parties and all. So some sort of study need to be done to that. And there was one very curious case which actually presented with a small subhyaloid hemorrhage right out the macula. Here also the history is only this. So that, I don't know, yes, taken part in a party. She says that she just looked at the light and this is what she has. Maybe there is some sort of Valsalva effort or something which was also there, but there is something which is curious going on about these lights.
So, Avarna, can we wrap up the session?
So I think today's session beautifully connected the past, present, and future of ophthalmic trauma, not just imparting knowledge, but it is thought-provoking also. And it clearly highlighted that the future of ophthalmic trauma lies in integrating the clinical expertise along with the data. It should be patient-based, patient-centric, and we should try to integrate AI and newer imaging modalities also. So, on behalf of KSOS, I sincerely thank Dr. Rupesh Agarwal sir for his outstanding and thought-provoking masterclass.
Thank you. Thank you so much. That's it.
I think she lost the connection.
Thank you.
So it's my privilege to thank you on behalf of KSOS and Scientific Committee. I think it's more than 11 p.m. now, their local time. It's great seeing you sitting and teaching us all from all your experience. Thanks a lot. I have listened to him many times. It's wonderful listening always. We wish to have you sometime in our annual conference in Kerala. It happens during November, December times. And I've seen that many guests are there in this talk. I mean, they have participated outside KSOS, especially Dr. Sushank and Dr. Chittaranjan. Thank you for participating in the discussion and making it live. My special gratitude and thanks to Dr. Bankule for participating. I know he's very busy every hour, every day, but he is one of the best multitasker I've ever seen. Thank you, sir, and thank you for
Thank you,
Dr.
Sujit.
Rupesh.
I'm a part of KSOS.
Thank you for that as well. And Biju sir, thank you. It is always 100% from him when it comes to KSOS, our past secretary. And thanks a lot, Aparna, for the flawless moderation of the session. And thank you all. A good night.
Good night. Good night, everyone.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you. Good night.
Thank